Hello, today we're talking about the drug Baracitinib and its role in revolutionising the treatment of rheumatoid arthritis. Today we have three speakers, Emma, and Ariel. So we're going to start talking about rheumatoid arthritis. It is a complicated and multifaceted disease. We still don't completely understand the etiology or the pathophysiology, but what we do know is it's a homeostatic imbalance of inflammatory mediators, and that's really driven by an immunological conflict. So it is an autoimmune disease. Patients present with joint tenderness, swelling, destruction of the synovial joint and the surrounding bone. It has a really big impact on patients. They have severe disability, decreased mobility, a really impaired quality of life, and also chronic pain that comes with that. If you'll have a look here, we do have a diagram. It's really simplified. It's got some of the potential causal factors, the disease progression and future outcomes there. Like I said before, we don't fully know what causes it, but we have got factors associated, which include genetic and biological markers, and also environmental factors. They're listed here below.
So the aims of treatment in rheumatoid arthritis are to provide symptom relief for the patient. We want to increase their mobility and quality of life. We also really focus on slowing disease progression, bone and joint damage, and the associated disability. The current guidelines state that we should use DMARDs, disease-modifying anti-rheumatic drugs, as soon as possible at diagnosis of rheumatoid arthritis. This is because they work on the inflammatory mediators that are implicated in disease progression. You can see where each of them work in this diagram here. Other drugs can be used, NSAIDs and corticosteroids, just providing rapid symptom relief at initial presentation and exacerbations. And the DMARDs are grouped into two categories, conventional and biological.
So the drug that we're talking about today is Baracitinib, which is a new type of targeted synthetic DMARD. So it works specifically on the genus kinase enzyme, which is also referred to as JAK. So it's a specific and reversible JAK1 and JAK2 enzyme inhibitor. So normally in the cell, cytokines and other mediators bind to the extracellular portion of the cell and activate the JAK enzyme intracellularly. This results in the phosphorylation of the STAT protein in the JAK-STAT pathway, which ultimately results in the production of inflammatory mediators listed here. These inflammatory mediators are crucial to the pathogenesis of rheumatoid arthritis. So by inhibiting the JAK enzyme, we ultimately inhibit the inflammation in rheumatoid arthritis. So we've looked at the efficacy of Baracitinib in a number of clinical trials and compared them using the ARC20 value. This value is used to evaluate not only clinical markers for rheumatoid arthritis, but also patients' personal assessment of how the disease is progressing. So as you can see here, the placebo in the yellow and the Baracitinib in the blue and the green in the first 4 trials show that Baracitinib has a significantly increased efficacy when compared to placebo. Also in the RAB trial, you can see that when Baracitinib is compared to another DMARD, it has a higher efficacy when using the ARC20 value to compare.
Okay, so agreeing with what Emma said, we can see from the evidence that there was a lot of symptom improvement, slow disease progression, and a mild and tolerable side effect profile. I'm just going to quickly highlight some limitations and weakness with this research. So all trials, because it is a new drug, were trialled by the developers of the drug Baracitinib. They were all done on a short-term basis, so we really lack any long-term data. They also failed to mention too much about drug interactions or toxicity risks. And we've finally got, through thorough searching through medical databases, we really couldn't find too much preclinical data. While saying that, none of these findings completely discredit none of these limitations completely discredit our findings. There is definitely some space in the future for more research. Things that we would want to see is the efficacy in the long-term trials, as well as the tolerability and safety amongst the RA population, as well as its introduction into the Australian market, because it has been yet to be approved by the TGA.
So the question is Baracitinib a promising future therapy? It's clear that the targeted DMARDs show superiority over the conventional DMARDs. This is because the targeted nature, it is quite efficacious, as well as limiting the immunosuppression and associated infection for the patient. From the compiled evidence we have here, it can be seen that Baracitinib does have a tolerable adverse effects profile, as well as being efficacious in combination with methotrexate and on its own. From this, we can conclude that there definitely is a potential for Baracitinib in treatment of RA.